Welcome, everyone. My name is Esra Saleh. I'm a program manager with the Center for Immigrant and Refugee Health. We're so glad you could join us today for this important discussion on strengthening refugee women's health through reproductive health literacy training. I'm also joined by my colleagues from CIRA who will be supporting today's webinar by managing the recording and assisting with any technical needs. Thank you so much, team. So before we start, there are a few housekeeping reminders. So this webinar will be recorded, and the recording and slides will be shared with all of you after the session. For questions, please use the Q&A box at the bottom of your screen, and feel free to type in your questions at any time, and we will address them during the Q&A session at the end of the webinar, moderated by my colleague Jasmine. And at the end of the session, we will share a pre-feedback survey. Please fill out the survey, and your input is valuable to us. Thank you so much. And before we begin, I would like to take a moment to wish a happy Ramadan to those who are observing. Thank you so much for joining. And today we are honored to have three expert speakers with us who bring a wealth of experience in public health, reproductive health education, and refugee health advocacy. To officially open today's session, I'm pleased to introduce Dr. Sadiq, the Executive Director of the Center for Immigrant and Refugee Health. Dr. Sadiq has been a strong advocate for improving women's health in refugee communities. We are glad to have him here today to introduce our discussion. Dr. Sadiq, the floor is yours.
Thank you, Dr. Very much appreciate the introduction. So, first of all, thank you everybody for attending the webinar and spending some time to attend this webinar out of your busy schedules. And this is an excellent topic. As Dr. Esra said, women's health is, first of all, such an important issue, critical issue, and also, a topic that I'm very much interested in as a research, as an area of practice. But the good news is that we have excellent speakers who are advocates, who has so much knowledge and expertise in this area. Dr. Heike, Dr. Fahim Pirzada, and Ms. Asiya Yama. Really much appreciate you coming here today to share your expertise with our community. As I said, women's health is so crucial, so much nuanced conversation around this topic. Women makes 50% of our society, and any intervention in women's health is actually having a ripple effect, not only on women, but also on children, on the family, and the community at large. So a really important discussion. And the other aspect of this topic is that many immigrant and refugee sending countries have gender specific cultural norms, and that's why it requires a very nuanced understanding, and this business as usual practice here is often not applicable when it comes to interventions related to women's health. We hear a lot of stories related to women facing barriers and issues and problems that they had back home, and they continue to have it here, and simply the problems that they have, the geography changes, but the problem continues to remain. So anyway, I don't want to go into that much of details because we have presenters who will fully cover that. Again, thank you, and I appreciate you being here with us. And I'll hand it over back to you, Dr. Esra and Jasmine. Thanks so much.
Thank you so much, Dr. Sadiq, for your remarks and for your leadership in this important area. Thank you so much. Now I will introduce the speaker. So first we have Dr. Heike Thiel de Bocanegra, a principal investigator and adjunct professor at UC Irvine, with over 25 years of experience in women's health. Dr. Heike has been a leader in addressing reproductive health disparities in refugee and marginalized communities. She founded the Refugee Reproductive Health Network, ReproNet, supporting over 500 newcomers. Next, we have Dr. Fahim Pirzada, a visiting professor at UC Davis and a subject matter expert with ReproNet, developing training materials and reproductive health toolkits to improve refugee women's health literacy and enhance cultural competency among healthcare providers. And finally, we have Asiya Yama, a project coordinator at ReproNet. Asiya has co-developed reproductive health literacy training materials, facilitating sessions with refugee women, and evaluating program impact. She brings hands-on experience working directly with refugee communities and healthcare providers to improve health education efforts. We are so grateful to have them with us today to share their expertise. And now, let me briefly walk you through today's agenda. We will start with an overview of refugee reproductive health, followed by a discussion on the difference between health education and health literacy. And then we will explore ways to normalize conversations about reproductive health and share case studies and examples. And finally, we will open the floor for Q&A session. And with that, let's get started. Dr. Heike, over to you.
Okay, good morning. It's very exciting to be able to talk to you today about refugee women's health and our experience of the past 5 years that we did as a network of ReproNet. And we have two additional speakers who are part of the refugee community, but the whole network is really consists of a lot of different community-based organizations, people who work on refugee studies and case managers. So it's really what we are sharing is not only based on one individual persons. We had received in the past funding from the Patient-Centered Outcome Research Institute and from the currently from the National Library of Medicine. And as Esra explained, we will we want to increase the comfort to address reproductive health issues among newcomers to the United States, explain a little bit the difference between health education and health literacy, learn about resources to integrate reproductive health issues into your own programs and your own work, and discuss some main considerations in addressing reproductive health in the clinic, school, and community setting. So first of all, what is reproductive health? And it is everything related to reproductive organs. So it includes issues of menstruation, fertility, cervical cancer screening, contraception, pregnancy, sexually transmissible infections, chronic health problems such as endometriosis and polycystic ovary syndrome, and menopause. And fertility issues and STDs, it's not limited only to women. So men as well and adolescents as well have reproductive health issues. And why is it important with reproductive health issues? There are so many priorities when refugees arrive, and about housing and getting the kids to school and getting a job and learning English but reproductive health impacts every woman. Everybody has menopause, and if you don't have menopause as a woman, then you have a medical problem. So some women with fertility concerns or health problems may have health problems that were not addressed in their home country, and they may come in here with extended pain, with bleeding, with other kind of problems, but also have, in most of the cultures, it's kind of a taboo to talk about sexual and reproductive health problems. Even here in the United States, it might not be something that women might be comfortable with bringing it up in a setting where they don't have a lot of trust or experience with. And as a result, when I started, like I worked for a long time as UCSF Family Pact Evaluation Director with the Office of Family Planning here in California for 12 years. And so I was very much into family planning. And then you kind of talk about contraceptive methods as if it's your daily bread or something. But when I then started talking to providers who are serving with refugees, like refugee resettlement agencies or ESL classes, or saying I often experienced a reluctance of providers and to talk about it. And one is a reason was that the expectation that women may not be interested in these issues, or may not be interested in talking to outside people about it, or that they have other priorities due to getting resettled, or as well that there is a concern if one brings up sexual and reproductive issues or talks about it, that it may be perceived as insensitive or offensive, that one all of a sudden says something that perhaps doesn't really, is not perceived well, and rather than offending somebody, then one prefers perhaps to stay away from the topic. So our goal of our Refugee Reproductive Health Network is to increase the awareness and kind of normalize conversations about reproductive health among newcomer communities, and to improve refugee women's ability to access health services and take care of their own health. Now, before we go on, it's really important to point out, when we say refugee women or women from Afghanistan or from Middle East, we kind of do it with broad strokes, and every woman is different. And when we did, for example, literature review at the beginning of our work on women's experiences with contraceptive care after resettlement in high-income countries, so also Canada and studies from Europe and Australia. I mean, we found a lot of differences in terms of priorities, preferences across the groups, but also within each group. So there are always exceptions to whatever statement we are doing, and we want to be mindful of that. So when women arrive as refugees or especially immigrant visa holders to the United States, there are roughly like 4 main touch points where one could bring up reproductive health issues. The first one is the refugee health assessment that each refugee gets scheduled for and receives within 90 days after arrival. And as most of you know, is that the federal refugee health assessment form, it's a standardized form for everybody in the States, and that one could add items on pregnancy intention or contraceptive use to this form. The second part is that the local health department, if the state does not add it, the questions to the refugee form, could do it for themselves, for their specific clients, or develop a local and integrated model, like to assess contraceptive needs or family planning needs or anything on reproductive health of newcomers. The third touch point, which impacts most of us is to integrate reproductive health into community programs and clinic education. So not necessarily like to have a whole program only on reproductive health, but we will describe later on kind of like how we integrate it into cultural orientation programs and other outreach. And for that point, we have developed, like ReproNet has developed reproductive health literacy training sessions, and as well gathered materials and curated, evaluated their accuracy in a reproductive digital library, so that we will focus on. And Medicaid managed care also has a role. Every immigrant or refugee is getting enrolled into Medicaid managed care plans. So in the ideal settings, you would have a refugee health assessment that looks at the contraceptive needs or pregnancy-related needs, and then informs the managed care plans. Okay, here is a woman who would with such and such issues, or for the managed care plan to do the contraceptive need upon enrollment and provide and refer as necessary. Does not necessarily happen right now, but back to the first point of the refugee health assessment. The federal form then assesses mainly infectious diseases and mental health problems, and then has the 5 reproductive health questions that you see listed here. So one assesses for pregnancy status, and then if a woman is pregnant at the time of arrival, she gets referred immediately to prenatal care. But there is nothing on contraception or anything else. Now, nationwide, you see of the Afghan arrivals that arrived in fiscal year 2022, that at about 10% of all the Afghan arrivals were pregnant, of the women. And then it kind of reduced in the last years to at about 5%. And that leaves all the women who are in this orange box, and I kind of shaded it, that nobody assesses their reproductive health needs at time of arrival. Now, the California Department of Public Health, Office of Refugee Health, they also, Christine Motto is also part of our steering committee, and we talked about it, and then in 2021, she added 2 questions to this federal form. So all 11 refugee clinics in California are assessing those questions. Do you think you want to be pregnant in the next 6 months? And if the answer is no, I don't want to be pregnant that soon, then would you like to discuss birth control or ways to prevent pregnancy or have a healthy pregnancy? So then I'm mentoring Javier Mola, who is a doctoral PhD student at the UC Davis Public Health Program, and he received a de-identified data set from the Office of Refugee Health for this period here from October 2022 to August 2023, and looked then at the responses of the pregnancy intention question. So of women, they were women between 15 and 49 years, so in reproductive health. And in the total sample of over 2,000 women, 9.5%, so nearly 10% said, yeah, I want to be pregnant in the next year, 6 months. And sometimes women want to be pregnant because now they feel safe in the conflict, when they're still in the process of refugee resettlement. They may not have been feeling this is not the right moment, and now I'm here in the United States, now I can get pregnant. So, and if you see it by country, Afghan women as well, nearly 10%, Ukrainian women, 8%, a little bit less. And the Americas is everybody who is from the Western Hemisphere, so Mexico, Central America, Haiti, South America. So those women, they're 10.4%. And then the women who said, no, I do not want to get pregnant that soon, they were asked for their interest in family planning services or to talk to a provider. And out of the sample, as well as for 8.5% who said, yes, I would like to talk to somebody. Afghan women as well, pretty much around the average. And Ukrainian women a lot less, 5%. And women from the Americas a lot higher. And this is kind of, one is the assessment was done, is being done as a family unit. And right after arrival to the United States, so Sometimes women might be surprised to be asked. They may not want to answer the question in front of other family members and may be more likely to say no. But even so, you have 10%. So that would be in this sample at about 180 women who would like to talk right now. And it's important that community agencies and clinics follow up on family planning needs, as well as alternator time for the people who said no. Very briefly, like the Ukrainian women, as you know, most of them who arrived in this period, 2021, 2022, arrived alone without their partners. And the partners, because of the Ukrainian war, stayed back in the military. So that may explain that why they might be less interested in talking to anybody about family planning services upon arrival. And the women from the Americas, this group includes as well asylees. So refugees and special immigrant visa holders receive this refugee health assessment within 90 days after arrival. An asylum seeker does not receive the assessment, but only when the asylum is granted, adjudicated, then they are scheduled for and when they then become asylees, and changing from asylum seeker to asylee, then the refugee health assessment is scheduled. So that's typically 1 to 2 years after arrival to the United States. So women might be more open and might be and interested in talking about family planning and women's health issues when they get this assessment. So we started so let me just check. Do you have any questions up to here that you would like to or comments?
There is one question in the chat, Dr. Heike, from Nahid, which is, what is your suggestion? Females in Afghan culture have to discuss with their husbands even though they want to learn about anything.
Well, this will be a great question for Dr. Fahim to discuss. And in part, we will discuss it as well in our case examples. So if you can hold on that question, and we hope to be able to talk about it and to address it. Okay. So moving on, if there are no other questions, moving on. So our Refugee Reproductive Health Network has done online and virtual meetings on refugee reproductive health issues to over 600 women in San Diego, Irvine, Southern California, in the Bay Area, Central Valley, but mainly as here in the Greater Sacramento area, and as well mainly to Afghan and Arabic-speaking refugees, but also especially with East African refugees and other ones. And we had done those sessions with refugee resettlement agencies, community groups like churches or community groups, Mars SSF, or in mosques as well. We published as well a study which you see there on whether women are receptive for virtual engagement. So are they really interested in Zoom meetings, and would they participate in Zoom meetings in the same way as online? And we will talk a little bit about those experiences. When we during COVID, when we had to switch to Zoom, we worked a lot with World Relief, which is one of the refugee resettlement agencies, and found that actually you can have the same impact and the same participation but in online if you have it as in person, if you kind of look at certain parameters and key elements. One is to plan ahead, and especially at the beginning of COVID, one had to train women how to use one-on-one, using how to use Zoom and how to use virtual platforms. Click on open, close the screen, mute, unmute, and as well getting the support of male partners. So not just going in, inviting women, but also informing the partners to say, this is what we are planning to do. We would like to talk about cervical cancer screening or about family planning. This here, you can check what will be talked about. So that's was important. In terms of Zoom meetings, reviewing privacy options. Is it possible for somebody to be alone in a room so that you can really kind of be private? We would always have all female meetings, which is even the panelists, the interpreter, the facilitator, the note takers, everything was women, and you have to open and close the, we are checking that every woman is female. With virtually, we did it a lot as part of cultural orientation sessions. So women would kind of a program. So they would, the same group of women would meet on a weekly basis, and then they would to talk about everything: how to take the bus, how to register the kids for school, how the school system works. Where to go for grocery shopping. And then after there was always already this trust established, they would invite us, so to speak, as experts on as invited guests, and then we would talk to the women about topics that they chose as well. Very clear protocols of confidentiality. What stays here, you don't share it with other people, kind of. And as a facilitator, showing respect, being non-judgmental. So if somebody says, I have 8 kids, I want a 9th kid, you are not like, oh my God, this is way too many kids or something. You just kind of like address the issue, whatever she brings forth, and make clear that learning is bidirectional. And that is something as well, typically like in the traditional learning setting, environmental settings, you have the teacher and the expert, and then you have the people who are the recipients, the students who are supposed to learn. What adult learning is about is that we all learn from each other. I have something to share, but you also have something to share where I can learn from. And I often, So this is kind of important. So kind of to have this attitude as well, that women, people, or even you here in the presentation as well, what you can share, that can inform everybody else. It doesn't have to be an invited speaker. Then what over time we really focused more on doing those conversations, those meetings on reproductive health, on health literacy, and focusing, which is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So that is really means that in practice, if you go this, that yes, you talk about cervical cancer and prevention and family planning and everything else, but you also say, how can you find information sources? Where did you hear something? If women ask, I heard such and such from your friends, from somebody else, you heard about it, saw it on WhatsApp, on social media, in the radio, and how accurate is that information? How can you verify that it's something reliable? The value of prevention, giving importance to own health and disease prevention, and empower women to communicate with the providers. So that are kind of mechanisms, approaches that go beyond just learning about, okay, this is what a pap smear stands for or something, but it's really empowering women to be literate and make decisions on their own health. And for that person as well, we developed a digital library, which is on the ReproNet.org website. And we curated those materials, really searched the internet, and with our national partners, CDC and Center of Excellence of Newcomer Health, Minnesota, etc., kind of to see where, and to have a collection. So if you, for example, as case manager, say, where can I start out finding information about maternal health, family planning, and good information that's medically accurate, up to date, and well translated, then please go onto this. You can go onto this web library, and everything it went through a vetting process. And with this one, I would like to ask my first question to one of my of the co-presenters. Is it possible to offer those type of sessions in the mosques? And what's your opinion and your experience?
Yes, thank you for that question. Of course, mosque and masjids, I would refer to it as a masjid, is another place beside community-based organization and centers to deliver sessions and education to the community. Mosque has been very successful in reaching out to large community members. They have registry, they have good communication channels like WhatsApp group, they have email groups, and they also have Friday prayers announcements. So of course, this is a place that can be very useful to reach out to the community to do any education, and especially reproductive health for women. Another thing is that most Muslims, they bring their children for their Sunday schools, Saturday schools, or they come Friday. So such sessions can be scheduled around the availability of the parents to come and attend these sessions. Also, masjids have community centers where from time to time they hold their conferences, meetings, trainings, and they have been very good in outreach. So certainly I would encourage to use masjids. And as we experienced and launched our first session for ReproNet in 2021 with Masjid Aisha. So the way we reach out was to first speak to the leadership. Most and all the masjids and mosques, they have their shura or their council or board. So we reach out to them, explain what the aims and goals, which they were very supportive and say that they want to participate and facilitate that. So the next step was to assign a female coordinator because the population or the average group were women. So we assigned a female coordinator for that, which was very helpful to reach out to the women in the community. And also the imams help us to spread the word during the Friday prayers, where most men and women attended the Friday prayers. And also that was a good tool or means to reach out to the men who needs. And that with this part, I want to touch with the question of Sister Nahid, that yes, men are part of women's reproductive health. It is a culture, and it's also a religious obligation of Muslim women to keep the husbands or the guardians in the loop, not for like, it doesn't mean a controlling, but it's an obligation, it's a religious obligation to share that information and ask for permission to seek any health and reproductive health services with the consent of the husband and guardian.
Yeah. Next question would be, I just messed something up here a bit. Next question would be, what would be a good topic to start reproductive health sessions? Like when we went to the Aisha Masjid Mosque, and you and Dr. Koga introduced me. And then we were thinking, because ideally you asked women what do you want to talk about, but we hadn't even met any of the women, so we couldn't kind of see what women were. And then we were thinking, like, how can you get started, kind of thing? And you suggested a topic. Which one was it?
Yes. So when we talk about women's reproductive health, and we start with sexual and reproductive health, the first word is kind of like triggering or a sensitive word. So what we did, because understanding that back in Afghanistan, because of the situation that most of my participants in the audience know, there's less health services delivery in Afghanistan due to the war and conflict. So reproductive health education is not happening at large in Afghanistan. So part of important health of the woman, which is breast cancer, cervical cancer, ovarian cancer, all these other aspects of reproductive health are not well addressed in Afghanistan. So we put this question there that, do you want to learn about cervical cancer? So when we asked this question, a lot of attention were brought up to this, and participants said, yes, we would love to know or learn more. And similarly, they come up with other questions that they had and also topics that they were interested in wanting to learn about. So definitely, it was a good opportunity to tell them that we can offer more education and information about women's reproductive health.
Mm-hmm. Yeah, and it was as well a good opportunity, like, to explain the concept of screening and prevention and early identification of abnormalities. Because a lot of women, as Sister Asiya will kind of say in a moment, as well, kind of when we started out with the sessions and said, what do you hear? What comes to mind when you hear the word cancer? It was typically death. Disease, and many people had, participants had experiences with some family member or somebody they knew who was very sick and had advanced stages of cancer because they were not screened on time. Sister Asiya, can you explain how, what type of tool we used? We used a specific cervical cancer education tool.
Yes, sure. Good afternoon. Assalamu alaikum, everyone. So for our sessions, or in general, we use the cervical cancer tool that's called Understanding Cervical Cancer Prevention tool that we developed with National Cervical Cancer Coalition and UCLA. And if you allow me to share my screen so I can. Okay. So what we do to introduce the cervical cancer tool, we first familiarize the women with its audio version, which is available in Arabic, Pashto, and Dari. And this allows them to share these resources with friends and family or revisit it like specific section letters. We show them how to navigate to, like, if you don't have the direct link, then you can look for the keywords, which is Understanding Cervical Cancer Prevention. And it's gonna send you to the National Cervical Cancer Coalition website or the landing page. And here we see that we have the tool in English and Spanish, and then we have the audio in Arabic, Pashto, and Dari. After that, we so depending on the language of the session, so they can select their language. Like, let's see, we choose Dari. And the training starts by explaining the anatomy of the female reproductive system. I'm gonna show that here, which helps clarify the difference between the cervix and the uterus. Also, the key topics covered in this tool are HPV, HPV vaccine, Pap smear, and the recommended screening schedules or guidelines. Many participants are unfamiliar with the word Pap smear, so that's what we noticed from the trainings. And some even confuse it with pelvic exams. So after explaining the procedure here, we have like small vignettes and which shows the whole procedure, like when you enter to, or when you get to the office, your provider's office, and getting the exam and what happens. So after they see the whole procedure, they realize that they have undergone the test, but they didn't know the name for it. So I'll stop and you can share your slides, Dr. Okay. Yeah.
Yes, just. Okay.
Yeah. Forward to the slide.
Yeah. And I put in the chat here's the link, and I put in when I go in, I normally Google NCCC, Understanding Cervical Cancer Prevention, and then it pops right up.
Okay. So next slide, please. Yeah. Actually, one more. Oh, sorry. So overall, what happened introducing this tool helps build knowledge about cervical cancer and awareness of preventative care. This tool also suggests questions, which you can see on that screenshot, that women may ask their provider at the clinic visit, such as, are there any specific treatment for HPV infection, or does my partner need to go to the doctor, in this case, which means spouse or husband. So in our cervical cancer training, we emphasize the importance of prevention for early detection and treatment. We begin by asking women how they feel when they hear the word cancer, which serves as a great icebreaker in those sessions. And this also leads to the discussion about personal experiences, such as knowing someone who had lost their life or who had cancer.
Mm-hmm. So are there any kind of differences between virtual and in-person sessions?
Yes, so there, can we go back to the slide, Doctor? One more. Yeah, so the topics. So during the trainings, women expressed interest in learning about various gynecologic cancers, including breast and ovarian cancer. And another highly requested topic is endometriosis. Some also requested information on modern contraceptive, their side effects, and some mentioned the importance of how to talk to adolescents, like young girls, about puberty and hygiene.
Mm-hmm. Yeah. So there is actually a question as well in the chat, I think, about adolescence. And we will talk about like one of the case examples from Dr. Fahim as well are about this topic. But to answer your questions, most of our sessions focused for adult women and over. But sometimes a couple of times we had some like 17-year-olds coming in as well to the sessions. What are the keys? Some of the key comments that people mentioned in the session evaluations.
Yes, so the key themes from our session evaluation forms included the importance of health education in helping women making informed decisions about childbirth. Many women commented that they felt unprepared for decisions during delivery, such as whether to receive an epidural or not. They preferred to receive more comprehensive information earlier in the pregnancy. Also, effective communication between patients and provider was a major concern. Some felt that providers didn't listen to their health needs, most likely due to language barriers, and they highlighted the need for proper interpretation services.
And again, any kind of differences between virtual and in-person sessions?
Yes, so there were notable differences between virtual and in-person sessions. For example, for our online Arabic session, we had high attendance, while in-person Arabic session, which was in El Grove, we saw very low turnout, and which was due to many Arab American residents being long-time immigrants, and they had their daytime commitments. For our Pashto initial group, it was similar. We had very low attendance, but that was due to scheduling conflict and transportation issues, which improved with better communication. So as I mentioned, that transportation was a significant barrier for Afghan participants attending in-person session. But the main challenge for our virtual session was verifying participants' identity, because some attendees, they would use generic name like iPhone or A's iPhone, or they joined from their spouse or son's Zoom account. So we had to ask them to unmute or like provide their name and rename themselves.
Okay, so what can you tell us about the family planning sessions that we conducted?
So from our family planning trainings, it's I would say that it's clear that the Afghan women do use modern contraception. It's not the use is not low in Afghanistan. However, the continuation rate is poor, and it's due to the misinformation and side effect, or the fear of side effect. So, like common concern was included IUD causing cancer, or arm implants leading to mood changes, or weight gain, or contraceptive methods affecting long-term fertility. So, when we start our session, the family planning session, we start with the basics such as understanding reproductive organs, which we do in the cervical cancer session and then the family planning session. And then we explain the menstrual cycle, and before covering natural family planning or modern contraceptive methods. We also discuss how to assess reliable information, whether it is from social media or community sources. But we also need to keep in mind that women often consult their spouses before choosing any type of contraception method, and family and friends also influence their decision. And misconception about medical intervention, or such as taking birth control pills for non-contraceptive reasons will affect fertility in the future. So we have to keep that in mind.
Yeah, and can you tell us a little bit about this slide and how about the recorded PowerPoint presentations that ReproNet developed and posted on YouTube and as well on the ReproNet digital library?
Yeah, so on this slide we see a PowerPoint presentation. It's on female birth control, and it shows, the screenshot shows like all 4 languages, English, Pashto, Dari, and Arabic. So we have ReproNet created video presentation on various reproductive health topics, and as I said, it's available in all 4 languages. What we do, we show the video in the language that best suits your audience. So like the audience for us would be if it's with our, like if you organize it with Work Relief or IRC, depending on the language, Pashto or Dari clients or Arabic clients. So we show that presentation in that language. And if we have the facilitator also in the same language group, like the native speaker, then they can do the Q&A. But let's see if the facilitator speaks different language, she doesn't speak the group's language, then we use interpreter or from to answer any questions. We also share the links for those presentations, and they're available on the ReproNet's YouTube channel and also on the repronet.org website digital library. So then they can watch it later, they can share it with others. But this is just a screenshot showing it's in similar format. We try to have it as similar as possible, just the language difference.
Yeah, and I found it very helpful, and sometimes there is nobody, no Pashto or Dari speaker available at a certain time when the community-based organization can set up a meeting. And then I can, for example, show the video in Pashto, and it's recorded by a Pashto speaker, and then I know exactly what they heard. I can stop the video, or the power. We have it also in PowerPoints, and we have the script, so I can stop it and can kind of and know exactly what women just heard. So then the interpreter asks then questions and answers, and then we can lead it then. And the other advantage is, if we ask somebody else to facilitate a session and they said, I have never talked about family planning, so so they can use the video, and you don't have to think like, what kind of content do I do? How do I do them? The animations, so that they are interesting to see. You can use the video and show it. And then we have also a frequently asked questions document on the website, where you can see in the past, what did women, when they talked about family planning or when they talked about cervical cancer, what kind of questions did they ask? So then you can get, and what are the answers for, like, generic answers. So that helps you to be a little bit more prepared on those topics. Let's go on with Dr. Fahim. So what are some of the issues in taking contraceptive use and in seeing adolescents in the clinic?
Thank you. Contraceptive discussion or topic is sensitive, especially for some certain refugee groups like Afghan refugees, because this is not an individual decision for most refugee group or for most Afghan women. So other family members can be involved or should be involved. For example, if a woman is married, so husband is part of that decision making. If a woman is single, then mother or father or any other guardian is part of that decision. So you will see different women with different needs and knowledge and awareness. They will come prepared with a decision about their contraceptive options, spacing out like pregnancy, and there are women that they have no knowledge, they have no understanding, and that will tell you that, let me talk to my husband, let me talk to my so-and-so family member, and we'll discuss it later. So I would encourage that we involve those people who are part of the decision makers. And specifically coming to a case study that I personally experienced that. So there was a 16-year-old young girl, a woman, experiencing irregular painful periods. And mother and sister came repeatedly to the provider discussing a similar issue, while the provider was suggesting pregnancy pills. This is the term that was used for this medical condition. However, mother was resistant. Mother was opposing and said, how come a single, unmarried daughter, 16-year-old, can be put on pregnancy pills, pregnancy prevention pills? So that was the time I noticed where this like gap is coming. So because I was providing interpretation for the session, I used to be the medical interpreter for that session. So I intervened. Medical interpreters, they have their limitations in terms of just to keep the transparency between the provider and patient, but sometimes those like limitation can prevent an interpreter to intervene and advocate for. In this case, I asked for the permission from the provider if I can provide additional advocacy or information on this topic that is a barrier between the provider and the patient. And luckily, the provider understood and was allowed me to. And then I explained to the provider that what is the reason for mother being resistant towards this hormonal therapy that the provider is offering. And then I also explained to mother that what is the reason and what is this medicine actually for. It is not to, because the mother was worried if someone sees those pills with this 16-year-old unmarried daughter, there could be some different or misconception or perception about that girl. So mom was protected and didn't know that this is a medicine, a therapeutic treatment, but not something related to pregnancy. So when both parties understood what it was, and then the mom was encouraged to allow the daughter to receive the treatment, and then the doctor corrected the medical term used, and said that I'm prescribing some hormones to treat this medical condition. That really changed the understanding and the position of mother. And then the mother said, okay, send me the prescription to so-and-so pharmacy. And so the important thing is that is how to consider the needs of your patient in the clinic, in the setting, and also to understand the knowledge and the awareness, and then using appropriate terms for that, like pregnancy pills versus medications, hormones, or whatever other terms that is available for you to use, and that encourage the patient to to use the medicines for that condition.
Thank you for this great example. So what are some considerations in taking contraceptive use and screening for STIs in the refugee population in general?
Yes, this is another very important consideration because STI screening does not happen back in the home country for Afghan refugees especially. So knowledge around STD, STI screening is limited. And also, generally when families are seen together, when the provider is asking about, is it okay to do a group screening, everyone or individually? And most refugee groups, especially Afghans, would say that, oh, it's fine to be seen collectively, but that does not mean that all sensitive and personal information can be discussed without checking again with the individual on one-on-one. So when it comes to STI screening, talking to adolescents, it's important to distinguish between men and women or boys and girls. With girls, the very first thing I would suggest to put this question, if that young woman is married or single. If it's single, then questions can be differently put to that one girl. Again, if a girl is with mom, so she has more convenience of discussing STI screening with the mom. But if a girl, 16, adolescent woman, 15, 17, is with father, then that is something to keep into consideration and tell them that if she wants to be alone and the question be on one-on-one. And of course, father can be informed about the discussions, and if both parties, father and daughter, agree for the individual screening, that's fine. If they still want to continue as together, you can proceed. But again, some of the questions, for example, how many sexual partners did you have over so-and-so? If a woman said, I'm single, especially for Afghan Muslim women, that question does not apply. However, if the provider still wants to ask the question can be rephrased about if the person have any relationship versus sexual partner. So those are the things that really triggers and build trust and mistrust between provider and the patient. In terms of male or boys discussions and screening, being married or single really does not apply, and the provider can still ask the consent from the parent and that adolescent whether they want to be seen or discuss together, or the patient wants to be alone and answer those questions. Because most these adolescents, they speak good English, so they would say, yeah, I'd like to be alone and answer questions. So the question can be put that if that boy or young man has any relationship versus asking that how many times that person had sexual relationship. So those are some of the consideration in the culture and the encouragement for your patients to answer your questions the way you want to check that box. So phrasing questions and also how to handle, that's something important. So please I encourage you to please take the time, even if you have consent for group screening, still consider individual screening, still look for those inconveniences in the room if they do not want to be seen in front of other family members. Give that opportunity and one-on-one discussion.
Adolescents or friends may often be asked to help bridge the language gaps because teens are more likely quicker to learn English. What may be some pitfalls when using untrained interpreters?
Yes, in many refugee families, it is normal to have another young family member to be as an interpreter, because that child or family member learned English quicker than the parents or other older family members. So when they come and fill out the forms, please take your time to review that forms and answers with your patient, so the patient is aware if different answers are provided or a box is checked. Also, there are some terms, medical terms, understanding English and medical literacy. These are the two different things. So a lot of teenagers or family members who speak English would be still willing to provide an interpretation, or will be resistant. Or even your patient will be saying that, no, I'm fine with so-and-so to provide that interpretation. But when it comes to sensitive screenings and when it comes to a certain medical conditions, it is best to use a trained professional medical interpreter so that the terms and medical condition is properly interpreted. For example, a cancer can be very like easily misinterpreted when the patient says, I have a bump, and then that's interpreted as a cancer. Or in Pashto or Dari, we say Dana. So a lot of Dana can be misinterpreted by a non-professional medical interpreter as a cancerous bump or mass. Or in mental health, there are also some terms a lot of traditional people or coming with low level of education may say that I have fashar pain, or I have in Pashto say I have fashar tidde. So that means that low blood pressure, but that low blood pressure could be a depression sign, something that is the patient is expressing sadness or depression. And also for anxiety, I heard many times from Afghan patients saying that I have high blood pressure. Then was not feeling well. My fashar was high or fashar bala. So that means that I was feeling anxious. I was irritable. So these are the terms and the idioms of distress that the patients are expressing, and these are the terms that if trained medical interpreter is used, those can be properly interpreted.
Great, and you can kind of relate to it as well with other languages. It's the same issues like of the need of talking about like making sure that the correct medical terms are being used. Sister Asiya, what type of questions came up in the sessions on maternal health and postpartum care? And if you could also say a little bit, did women really open up and talk about their participate about sexual reproductive health?
Yes, so I'll answer the first part, which is the question, especially on maternal health and postpartum care. We usually show 2 video presentations, and it covers the postpartum period and also let's say if they experience a miscarriage. So the question on the postpartum care, many women are unfamiliar with the need for monthly prenatal care visits and screenings here in the U.S. Because the standard care in Afghanistan includes only 4 visits. So they do ask, like, why do we have to go every month, or why do we need to test that often? So even though the maternal health discussion were not like highly requested, they kind of, but when we showed the video on the pregnancy loss, they showed strong interest in learning about pregnancy loss, fertility, because of the cultural expectation around childbirth. And the challenges, especially like difficulties in conceiving, the major concern along with the need to address the stigma surrounding miscarriage. So these were like the questions that came up. For the postpartum, we emphasize on self-care and preventative care. Postpartum care is a key focus. We share that so because the attention often shifts to the infant. So women, when we share that, the women recognize the importance of self-care in the first 6 weeks after birth, but they informed us, they noted that the lack of support system in their new communities here, that's like they know that they need it, but they don't have that support system. So we also, in those videos, we highlighted the postpartum depression, signs for postpartum depression, especially for women who have experienced trauma. As the second part was like if they open up or if they mention in the beginning, they are hesitant. And we have seen the difference between two language groups, Dari and Pashto. But sometimes it's really, as I mentioned earlier, like the asking them, like, if you do you know anything about cancer? So similar question around this topic. Then one person volunteers, and then we see like lots of engagement, lots of participation. After that, they then start to share their personal stories, if they experience any miscarriage, if they have challenges in conceiving and all that. So after, and usually this is the third session. If we do like a series, so this is the third session. We have that, we built that trust, and they really participate then.
Yeah, thank you. So this is really like, it's just a snapshot of what we have done in the past. And for me, as well, when I was sitting in the sessions and observing, it was really compelling how women really, and as well said, this is so great that we can discuss this in this forum. So this whole idea, women might be apprehensive or might not want to talk or might not want to share because they don't necessarily know the other person. Once you have this community of women, it's extremely personal questions and applied. And in part, I think it's because of the type of facilitators that we select and the comfort and creating this environment of trust. We also give women as resources QR codes. We have several women, sometimes who may not be able to read and write in their own language. So it's not like you can't really easily give handouts, but women, especially with COVID now, are used to have QR codes or text messages, video. That's why we came up with the video recordings that helps women to talk about it and to check out the information themselves. We tell them as well, and after we show the videos, we say, this is available on YouTube, it's available on our digital library. Show it afterwards to your partners, to your husbands, to your family members. So again, involving men and kind of, so it's not something, oh, here are the women talking to each other and the men don't even know what has been discussed. No? So just to let you know as well, we on our ReproNet.org websites, we have a whole provider tab, and where we can then, you can have the PowerPoints, the video recordings, the script. Sometimes when we ask somebody to do a session in Pashto, then give them then the script to the video so they can kind of see like which kind of words were used and terms. And we say how they can be used. We also developed, as I said earlier, a frequently asked questions a document so that you can prepare as well for the discussion. Bottom line of everything is it is possible to engage refugee women in reproductive health discussions and improve health literacy. And we have good session evaluation results and so don't be shy. But if you want to use do reproductive health literacy sessions or talk about, well, please contact us. We are more than happy to mentor, to advise, to help you to use the materials or any other questions that you may have. So I will stop share now and check which other questions came up in the chat or in the questions and answers. So there were two questions. One on adolescence, which I hope we have had answers. Well, we said from your experience working with refugee women, what topics in reproductive health would you say is most asked about by them? I think we answered that questions. It was mainly cervical cancer, maternal health, family planning, and as well endometriosis. We also just did now a session on menopause, which was very well intended. We talked about adolescence. And let me see whether there's anything else in the chat, or please feel free to put it in the chat or in the questions.
I also see that someone has their hand raised. I'm going to try and see if I can allow you to ask your question out loud. If not, would you please... Okay, I can... So I think you should be able to ask your question now off of mute if you'd like.
Hi.
Yeah, we hear you.
Hi. Thank you for this beautiful presentation. I was wondering if there is any resource that you can share with us in regards of postpartum depression. I don't know how much you guys agree with me. It's hard to convince, especially Afghan women, in regards of mental health care, and it's very important topic, like the postpartum depression. Is there any resources that you can share how to use, how to approach, and how to convince them to pay attention to this matter?
Asiya, do you want to answer this?
Yeah, so we have the video, as I mentioned, which focuses on the key points, or it talks about like the signs and symptoms, and the importance of the screening. And in addition to that video, we can always, as I mentioned first, the question comes up that why do we have so many appointments, like prenatal visits? I know so even that's a good time to discuss that, hey, after you have the baby, after you deliver the baby, you still have to look for these, and you need to go to the doctor in case if you feel, as Dr. Pirzada mentioned, low blood pressure, high blood pressure, maybe it's a sign that they are not feeling well or there is an issue. So convincing them, personally, we have the video, but we are also looking for more materials in Pashto and Dari. And we have some on the digital library, but we will share the links with you.
Yeah, and so the Center of Excellence on Newcomer Health from Minnesota, actually, I think yesterday they did a whole session on focusing on postpartum mental health. Nationwide webinar, which is probably will be then later on as well posted on their session, and that's really an important issue. Like in this video, we kind of show them as well. Say yes, everybody has the blues sometimes, but when is it getting that severe that you may want to seek help, and really trying to get the stigma out of it, of being.
And additionally, I would like to comment that we have to discuss that during the pregnancy, not after they have the baby, because then they are so busy with the baby that even though they have all that issues, they will have the signs and symptoms, but they may not know, or they're so consumed with the taking care of the baby that they don't pay attention to their self or like to their health. So if you mention that like throughout the pregnancy and then after they have the baby and they feel that, so then they can get help and reach out.
I wanted to also add this, that the level of literacy about mental health among refugee population is unfortunately not that high, especially in Afghan women. So how we can literate them about importance can be provided with emojis and in their own languages. Let's say if you provide short videos that shows emotions and how they feel specifically for postpartum depression, using the local or native words instead of like As Dr. Ahmad was mentioning, like my pressure is high. If someone else hears that, they think that their blood pressure is high, but the mental pressure, the pressure of life is high with that person, but they don't know. They have to be literated about mental health, and it can be provided with short videos. Even short emojis can be helpful because of the the language barrier, and also some of them have never been in school. I think visual education is more helpful for those cases.
Dr. Fahim, he had some comments as well. He is an expert on mental health.
Yeah. So one thing I would like to elaborate is pregnancy generally among Muslim women and Afghan women perceived positive. So there is a positivity towards that change in the body. That is why even if postpartum depression or during pregnancy that depression happens, it is kind of like ignored. So, and the knowledge of women is very important to understand. Back in 2015 and 16, when I was running a nonprofit organization, I developed a pamphlet about understanding signs and symptoms of anxiety, depression, post-traumatic stress disorder, because people, they need to know if they feel something. Even a generalized body pain can be a sign of a depression, but a lot of our community people, they do not understand. There's no awareness. Even the tools, the screening tools we use during the OBGYN postpartum screening, that questionnaire, that tool does not meet the cultural needs or the need of that woman. So a lot of those questions, the options are so difficult for women to understand. That's why you don't really get an engagement, an interest, because some women, they come repeatedly for their visits, and again, hear those questions, did not understand. I said, what is this funny side of things? This person is asking me that. So again, it's about the knowledge, awareness, and also the positive mentality of women towards the pregnancy. Those are the things that makes the difference in terms of discussion that. But here in the US, this is the postpartum is an important thing, and it should not be ignored, because back in their home country, they had large family support. There was mother-in-law, there was sisters, siblings, other large family providing support. So women never thought about a depression or anxiety signs and symptoms because there was help. But here, 12 or 10 hours working husband, children at school, pregnant woman alone, doesn't know how to care for herself, to get to the appointments. So all these things, automatically cause that depression and anxiety for pregnant women. So we need to bring that. I agree with you. Dr. Heike knows about the need for postpartum interventions and tools where we can bring more resources, first of all, for refugee women, second of all, for our providers, so they can understand and communicate and facilitate the services. Well, so hopefully
thank you so much. Thank you so much, Dr. Fahim. And also, I want to bring this, since you all are here. I have been discussing about mental health in children, refugee children. If you guys can please have some resources shared with us. And also, Dr. Fahim, you mentioned a very nice word, interest. We need to build that interest in pregnant women and newly moms, or the moms who have babies, to find that interest in their mental health. Thank you so much again.
I would like also to say, like in the chat, the Center on Immigrant and Refugee Health said that they had hosted a session on mental health, not limited to postpartum mental health, previous, which you may want to consult. And also there was in the chat a question that Dr. Fahim answered about what happens if the partner is impeding reproductive health issues. And one issue is as well, partner relationships are very varied in the Afghan community, in any other refugee community here in the United States. And you have some partners who are very supportive of women's reproductive health, who even encouraged women to go to the refugee, like to orientation sessions and to learn more. Now here you can now learn more. And you have other partners who even outright impeding reproductive health and maybe abusive. And we have here in Sacramento a shelter for women, for Muslim women who are experiences abuse, and you have everything in between. So I'm not sure whether within the 1 minute that we still have left before we have to wrap up, Fahim, you want to kind of like talk a little bit more to that particular question, because I think that's something that's important to keep in mind.
Which questions?
The question which says here, what if the husband denies the reproductive health care? Sometimes it is because of a lack of information as well as less knowledge. How are those cases handled?
Yes. So again, communication involving the partner in the discussions. Remember, most Afghan men are also not very well educated in reproductive health, and they're even their own sexual health. So providing that information or keeping them in the discussion involving facilitate, first of all, the service delivery. It prevents a lot of the waste of time and resources for provider, repeatedly educating and talking about the same subject, and while the patient is not very well receptive or understanding, because another important part of that discussion, which is the husband, is missing there. So encourage to have the husband in one of those sessions, so they both receive the information from provider, the awareness, and then ask them what options will best suit their needs as a husband and wife. And if the husband is educated and aware of the benefits, certainly there will be support and more like positive outcome from the both parties to follow the recommendations of provider.
Thank you very much. I know we have to wrap up now. Esther? Okay.
Thank you so much. Thank you so much, Dr. Heike, Dr. Fahim, and Sister Asiya for such an insightful discussion. We truly appreciate the expertise and perspectives shared today about women's health among refugee population. Thank you so much, and thanks for those who attended the webinar. And before we close, please take a moment to complete our feedback survey. It helps us improve future sessions. And to stay updated on future webinars and training, please subscribe to our newsletter and visit our website at sira.phi.org.